Welcome to this Umbi Podcast, and this episode I'm joined by Dr. Rageshri Dhairyawan. I'm Dr. Sita Raja, obstetrics and gynecology doctor and founder of Umbi. Today, this episode is about not being listened to, not being believed as a patient in the healthcare system, why that is, all the many reasons why that is, and also practically what you can do about it. Dr. Rageshri is a consultant in sexual health and HIV medicine at Barts Health. You're an honorary senior lecturer at Queen Mary University London. You worked with the Share Collaborative, where you do work on health equity quite broadly, but specifically to do with sexual health and HIV. We've worked together on academic projects before as part of the organisation Race and Health, particularly looking at how discrimination affects health and what can be done about it. Mm-hmm. This is quite cool. You were named as a woman changing the world on International Women's Day in 2019. How does that feel to be a woman changing the world?
Bit of a shocker, to be honest.
But that was for the work that you've done to kind of move things forward for women who are racially minoritized, living with HIV in that field of sexual health.
Yes.
Now, I know that you're an experienced speaker, an experienced writer, and that you really care. I really feel that you care about what you're doing, which is why I guess you've been an advocate and activist in the 20 years that you've been a doctor.
Yeah, absolutely.
And so I guess you're part of lots of these networks of collaborative organising about trying to make things better for people living with various health outcomes. Mm-hmm. And one of the things that you've been, your more recent project is this book that you're writing.
Yes.
And this book very much ties into this theme today, which is about, it's called Unheard. I like the images that I've seen so far on a prescription as a possible solution. I like that it's kind of focusing on what we can do as a solution.
Yeah.
But this kind of understanding that there are lots of people everywhere who are not being listened to, mm-hmm. who are not being believed. There are stories that are not being told. Mm-hmm. But there are reasons why that is. Mm-hmm. And we are all kind of part of those reasons of why that is and what we do about it.
Yep.
Do you want to tell us a bit about your book and what the theme is?
Yes. First of all, thank you so much for inviting me to be on
my
this
pleasure.
podcast. And it's so nice because I've worked with you before, but to be asked to talk about this as well is lovely. So thank you very much. So my book is called Unheard, The Medical Practice of Silencing. And it's kind of been probably about 10 years in the making, both from my experiences of being a medic for the last 20 years, working with minoritized communities, thinking about health inequalities, but I think it's also from my experiences of being a patient. So probably more than 10 years ago now, I was admitted to hospital. So I was having IVF because I have a very common menstrual condition called endometriosis. And it meant that I had to have IVF, and I was admitted with quite a lot of pain. So I was in for a couple of days while they did tests. And whilst I was in, I was basically denied adequate pain relief. So I was admitted on the ward and I was asking for stronger pain relief, and they just wouldn't give it to me. And I was treated like a bit of a nuisance. I felt very disbelieved and unlistened to and generally unheard. And I was very lucky because my husband was there advocating for me. And also I knew people that worked in that hospital who also came to visit me and advocate for me as well. And in the end, I was fine. I went home and I was very upset, and I thought I should really complain about my experience, but I didn't complain about it. And I can remember thinking months later that I felt really ashamed that I hadn't complained, and I hadn't complained enough at the time, and I felt like I'd been really silent. So this big feeling of shame, but also of guilt, because I was in a very privileged position. I was NHS doctor. I'd just become a consultant at the time, so a senior doctor. I knew how the NHS worked. I had someone to advocate for me. I could speak English. I didn't have a life-threatening condition. But if that could happen to me, if I could be silenced by that, what on earth happens to everyone else? And that made me feel guilty as well. I thought, by not speaking up myself, how I wasn't helping other people who were in a worse position than me. So I think I kind of sat on it for years. And then I suddenly, I started to talk about it more in presentations, and I started to write about it. And that's really kind of been the impetus for this book, Unheard, which really looks at how not listening is ingrained in our medical culture, sadly, and it affects patients in different ways, but particularly minoritized patients. But I really wanted it to be a positive book to look at what we can do. And I think when we talk to people, we hear it all the time that people say that they feel gaslit, they feel unheard or disbelieved by their doctors. The response commonly is, well, just speak up, speak louder, stick up for yourself. But I think there are lots of reasons why people don't do that. And for me, I think it is the healthcare service that has to change. We need to be better at listening. So that's what the book is about.
Wow. And I guess that's also the theme of what we're talking about today.
Yeah.
It's about why are some people not listened to in the healthcare system? Why are some stories told and others not? Why do we understand certain conditions better than others? And why are experiences of healthcare so variable?
Yes.
I think that's all kind of linked to what we're talking about.
Absolutely.
And we're trying to make it quite accessible today, but I was wondering if you can tell me about some of the academic definitions.
Yes. So something that really helped me understand my experiences was coming across this thing from philosophy. My husband is a philosopher, which is he introduced me to this. So it's a term called epistemic injustice, which was coined by a British philosopher called Miranda Fricker back in 2007. And it's basically described as a wrongdoing occurring to someone in their capacity as a knower. So to kind of explain that a bit further, something that makes us, it's an important part of our humanity, is being able to produce knowledge. So to say something and then to pass it on. So to feel like what you've said has been heard and listened to. And when that doesn't happen to us for various reasons, we feel dehumanized and less than human. So this is a real injustice, which is epistemic injustice. And Fricker came up with a couple of types, and other philosophers since then have extended kind of the concept further. I think one of the most important ones in healthcare is one called testimonial injustice. So this is when someone speaks and that they are less likely to be listened to and believed due to stereotypes about their identity. So, for example, some people are just seen as being less credible speakers, less trustworthy, less sincere. And this is often due to things like their gender, for example, their age, their ethnicity, their ability. So we see this in healthcare, for example, where someone goes to their doctor and says, I have this symptom, and the doctor just doesn't believe them. They doubt what they say. And as we know, unfortunately, this can happen more likely to women, for example, or women of colour. And when this happens again and again, when people are doubted again and again, very understandably, this leads to poor health outcomes. So delayed diagnosis, delayed treatment. And I think it really leads to silencing, because if you think, I'm going to my doctor, I'm telling them, my deepest woes, my concerns, and they're like, it's nothing. You feel gaslit, and then you just stop speaking. You get silenced. You censor yourself. And I think this is unfortunately something that happens in many aspects of society, but in healthcare, it has real damaging effects.
You lose trust, right? You lose trust in the system that you feel, in theory, you should go and interact with this healthcare system and feel seen. And yes, a plan is made together. Yeah. Collaboratively. It's interesting what you say in terms of that definition, because one of the projects that we worked on was obviously this, we wrote this Lancet series, so a series of academic papers looking at racism and discrimination based on caste, ethnicity, indigeneity, migratory status, and kind of mapping that onto health outcomes. So how does that affect health all around the world? And one of my roles in writing this is I wrote a glossary, so a series of definitions that came up when I was looking at all the theories. What are the key concepts we need to understand if we're to understand how discrimination affects health? So obviously I had to write about epistemic injustice. Yes. And it's quite interesting because it made a lot of sense to me, included it. And actually in the series of editing the papers, as you know what it's like when you're writing these big global series, so many people involved there. They're the reviewers, the editors, etc. I thought it was quite ironic, but actually epistemic injustice was edited out.
Oh, really?
Of the paper in one of the I mean, we worked on it for years, but one of those early iterations. And I was like, we're kind of doing what it is by not talking about it. So I really had to advocate. I was like, we have to speak about it. It has to be in there. And there's long, lengthy discussions. Okay, maybe it doesn't need to be in the main part. Maybe it can go in the appendix. Maybe you just talk about it in a different paper. And I was like, actually, this is kind of at the core of what we're talking about. There are lots of ways in which people are treated differently, but there's this common theme of people not being listened to or believed or valued in what they have to say. Yes. How does that affect how certain groups have been discriminated against, or even just certain groups? How does that affect how they internalize those beliefs, or do they internalize those? But how does that affect how you see yourself and then how you interact with the healthcare system?
I think it can make you feel like what you have to say isn't important. I think it can have a big impact on your self-esteem. You may feel less likely to advocate for yourself because you may feel, no one's going to listen to me anyway, so why should I do this? So I think it's a huge impact on patients. I think it's something that happens in other parts of the healthcare system as well, which can impact on people's health. So we see it amongst minoritized people, for example. So we know that minoritized doctors and researchers are, again, less likely to be heard, to experience epistemic injustice. And it means that the knowledge they produce is seen as less credible, less important. So, they're less likely to develop a policy that may affect, patient groups from their community, for example. So we see deficiencies in healthcare for those certain groups.
Right.
And just to give you an example, if you think about, for example, a very common condition, sickle cell disease, it's only recently that it's really got attention in terms of policy and research, because it's taken a long time for the healthcare workers and researchers and patients to be heard. And it's only now that we're seeing, advances in research.
Yeah. And I mean, I know you spoke about your endometriosis journey earlier, and I also have endometriosis, but it's like a classic example, isn't it? Something that affects 1 in 10 women. Is something that takes on average 8 years to be diagnosed in the UK. And 10 years ago, it took 8 years to be diagnosed in the UK.
Yes.
And also when I see patients every day with endometriosis, I have to tell them that I actually don't know. There's so much I don't know.
Yes. Yes.
And I think there's a reason why we don't know that much about it.
Yeah.
There's a reason we don't know that much about fibroids, So and sometimes I find in the healthcare system, clinicians are expected to know everything.
Yes.
But sometimes one of our roles is saying, I don't know that.
Yeah.
I know this. I feel confident that it's not this or this because of this, but I don't know about this.
Yeah.
And I think that's not something I was necessarily taught when training to be a doctor.
Yes.
Now, you've been a doctor for longer than I have. So how do you think it's changed over the years in terms of this relationship between, say, a doctor and a patient? And how does that contribute to this dynamic?
So I think one of the main things between doctors and patients is remembering there's always a power imbalance there. And I think sometimes we as doctors are not always conscious of that. I think what you've said about uncertainty is really interesting, because I think people generally go into healthcare to kind of help people. And we want to think that we know what's wrong with someone, that we can make a diagnosis and we can hopefully fix them, that they get better. And then when we don't know the answer, it's really uncomfortable for us then to speak to the patient. It's one of the things that makes us less likely to listen to a patient. So if you have a patient, say, for example, with a chronic pain disease, so something that you feel that you can't really help them with, you're more likely to shut them down and not listen to them. And it's often, people with chronic conditions like chronic pain who feel unheard because the doctor finds it just too uncomfortable to talk to them. And I think that's one of the problems which comes all the way from medical school, is that we are uncomfortable with conditions and patients that we don't know how to treat. And actually, we know from research that sometimes these patients who have conditions which are more difficult to understand or treat would like to be validated when they see their doctor. They'd like to be listened to. And perhaps we don't see our roles enough as being that. We want to provide a prescription, when actually if we listen and validate what someone is telling us, that in itself may be therapeutic, but it's not valued as such.
Yeah. So obviously our overall theme in this podcast is pregnancy, whether someone is trying to become pregnant or is pregnant or are somewhere in their kind of parenting journey, or maybe they're even thinking about if they want to be a parent. So I want to kind of bring this back, these ideas of not being listened to, not being heard, and bring that back to pregnancy. And there's an example that I always use that I saw in your book proposal as well. It's one of my favourite examples about Serena Williams. Once she had her baby and her experience of not being listened to. And I use this as an example because sometimes when you're looking at different reasons why people are discriminated, sometimes people try to conflate the colour of someone's skin with socioeconomic status.
Yes.
And this is a great example of one of the most well-known people on this earth, and the most successful, access to resources, who was not believed of her experiences. And I think that might be a good way to link how this could affect anyone in their pregnancy journey. So I was wondering if you could tell us a bit about that.
Yeah, so I use it as an example right at the beginning of my book, because if it can happen to Serena Williams, it can happen to anyone really. I think when I was researching my book, I was very conscious that all these things are more likely to happen to minoritized people. So due to stereotypes. So for example, when we can see it from some of the reports investigating poor maternity outcomes in the UK, where women of colour are always, they often say that they're told that they're too angry or they're too anxious. And these are the reasons why they weren't listened to when they really needed to be. So these stereotypes really fit in there. But I think what I found really interesting in my research was actually kind of we as doctors are taught not to believe patients. We're taught to doubt them right from our medical training. So we're taught to keep a distance from patients, and that in some ways can be good. We can be objective about them.
Do you remember? Sorry,
No.
Never trust the patient.
That was something. Were you actually taught that?
Never trust that. Don't trust them. Because they were trying to. I remember this so well. They're like, patient will come in and tell you they've had a migraine, and then you take a history and you find out what they're talking about is something else. Never trust the patient.
Yes.
I remember that was. Yeah.
So
to me,
we're taught to be skeptical of what people tell us, and it's ingrained in the language of medicine. So patient claims to be this, patient denies this. So we are taught right from the start to inherently doubt what patients tell us. And we also feel that patients perhaps are less likely to be objective about their illnesses. So, they can't keep a distance from themselves, and what they tell us should be doubted, or they may be seen to be less credible because, they might be incapacitated in some way because they're ill. So patients actually already have a credibility deficit, but it is minoritized patients who have it worse than others. So we see it, for example, with Serena Williams being a Black woman in healthcare, not being believed. So sadly, I think it's something that can affect anybody, but does affect minoritized patients.
Yeah, because I think she was saying that there's something not right after she'd had her baby, and she was like, I think I've got a blood clot.
Yes.
I think I've got a blood clot. And from what, obviously I wasn't there, but she wasn't listened to, and she did have a blood clot when they finally investigated that. And it's interesting because I see this all the time. I see this in maternity all the time. And I've worked in other countries, and I remember this thing about what you were saying about stereotypes and tropes.
Yeah.
Oh my goodness, it's everywhere.
Yes.
And actually it does tend to be linked to what you look like or where you're from.
Mm-hmm.
So I remember being kind of by the kind of central station on the labour ward, and they're like, oh, she just keeps ringing that bell. She's always just calling for me to come in. She just needs to stand up and get out of bed, she just, because she'd had a baby.
Yeah.
And I was like, oh, let me just go in and see if I can help.
Yeah.
And I went in, I was like, she doesn't look great. And I just lifted her sheet, and actually this patient was hemorrhaging and was bleeding, and she happened to be South Asian.
Yeah.
And there is this trope, South Asian women, they don't cope with pain that well.
Yes.
They're always asking for help. They're so spoiled,
Yeah.
And this woman, and I said, no, she's not just calling for help. So I had to call the emergency buzzer and manage that as an emergency. But that's quite an extreme situation, right? But that's someone who was quite literally calling for help, not feeling well, and needed urgent medical care, and didn't get it because of what people thought about her. And then I've seen on the other side, she's making such a fuss, she's so angry, she's not even in that much pain, And who is it that tends to be not believed in terms of their pain? It tends to be Black women. So,
exactly.
And there's loads of reasons historically about why this has come to be. And to be honest, I think it's helpful to understand that. But right now, I think it's important as healthcare professionals to be aware of those biases that shape the way that people interact with the world.
Yeah.
And also to recognise that, yes, we can be patients that experience this, but as healthcare professionals or as people, we are going to hold those biases as well.
Yes.
Everybody has these biases because we've been conditioned to think or hold those beliefs. So how do you navigate a world in which you're a consultant in sexual health and HIV? Mm-hmm. You've written and you've clearly thought so deeply about different ways in people access care and different ways in which we think.
Mm-hmm.
How do you hold that in your head and then sometimes recognize, are there encounters where you're like, oh wow, why did I say that? Is there a reason? Because you obviously will have them as well, right?
Absolutely.
It's not like it happens over there and not here. It happens every day inside us.
I've written a whole chapter about why doctors don't listen. I start off with responding to complaint that I got. So yes, I am also guilty of not listening. And when I was writing the book, I was very lucky in the planning of it to have a year out to do a master's. And I came back to work thinking I'm going to be this amazing listener. And after a few months, I was like, wow, listening is really hard. I've had a really busy clinic, and I'm sure I wasn't the best listener at the end of that clinic. I was knackered and other stuff had been going on. I could have been better in that consultation. So I think constant self-reflection is important. when it comes to bias, again, as you said, being aware that we all have it, but when is it more likely to rear its head? So again, it's when we're tired and when we're stressed. So,
Exactly.
if you are working in emergency care, for example, or you're doing a long on call, you're tired, you're more likely to kind of go to what we call heuristics or mental shortcuts. So we use stereotypes for people. We're more likely to do that when we're tired and stressed. So being aware of that means that, we can question ourselves at those times and say, am I making this right treatment or diagnosis decision based on a stereotype that I've got in my head, or does the evidence show that this is the case?
I remember coming across the evidence when writing those series that shows that if you've got staff shortages and huge volume of workload, then actually healthcare workers that's often conditions that are ripe for people to be discriminated against other people.
Yeah.
Which makes sense when you explain it like that you're using mental shortcuts. But I guess what you're saying is, even an awareness of that, to kind of just pause and check what you're doing. I found something that's quite helpful is that I just ask at the end of after I summarise at the end of the consultation to make sure that what I think is happening is what the patient thinks is happening. I just say, do you think there's anything I've missed?
Yeah.
And it doesn't always work. And also, usually there is if I'm tired, I was like, oh yeah, I forgot to write you this prescription or this or something. But just to have a bit of an open space between you and the person that you're with.
Yes.
To kind of figure out something together.
Yeah. Yeah.
I don't know if I'm being overly optimistic, but I think this power dynamic between patients and doctors is changing. Do you think that's the case?
That's a really interesting question. I would like to think that's the case, but I'm not sure. I think collectively patients have got a louder voice than they used to have. So through collectivizing, and in my book, I use the example of people living with HIV who pretty much had to fight for any treatment and care, and they did that collectively. So I think collectively, there's more patient organisations who have a voice. There's some amazing ones in maternity.
Yeah.
For example, I still think perhaps there is still that quite a big power balance on an individual level when you're in the consultation room with the doctor. And it's so interesting. So my mum is a retired GP, so South Asian mum. She will get dressed up to go and see her GP because she wants to be taken seriously, and she knows that power imbalance is there, even though she'll always say, I'm a retired doctor, so they know, but she feels the need to readdress that power imbalance somewhat. So I think as individuals there.
Yeah, maybe. Yeah, I had this encounter probably last month, and I had a flare of my asthma. Now, for reference, my asthma is fine. I've got one salbutamol inhaler. I haven't had many flares since I was a child. But this was quite severe. I was in the middle of a spin class, which I go to quite often, and I felt so unwell. It took me ages to figure out what was going on because it was I didn't recognise it. And over the course of 3.5 weeks, I was having a flare of asthma for 3.5 weeks, which is not how long that should be.
No, it's a long flare.
I was trying to access care. So I was in this situation where my breathing is so bad that I need to be taking my blue inhaler 4 to 5 times a day, which is not normal. But it's not so bad that I needed to go to A&E, that I needed a nebulizer. And so the perfect place for me to seek my care would be my GP. This is something that can be managed in the community, and I think one of the conditions and ways in which that's presenting that warrants a review with the doctor. Yeah, I don't think I'm being unreasonable in that. So difficult.
Really,
I still haven't seen a GP at my practice. I was asked to see the nurse. I said, that's fine, I don't mind as long as they're there's loads of nurse practitioners that are more than qualified to deal with this. But I got told, this is your fault.
Oh, wow.
I got told, is it really that bad? I said, well, I've just walked 4 minutes and I'm wheezing. So
that's not normal.
Yeah. I asked, can you examine me? I'm not qualified to examine you. I asked for a prescription for steroids, and I said, I was told absolutely no way, no one to give me steroids. So this long protracted interaction of me, and I was spending so many days off from work trying to go to the GP, but also thinking I don't want to go to A&E to, I'm trying to be a doctor thinking this is not the most appropriate scenario to go to A&E. Yeah. But 3.5 weeks of not being believed, being told it's my fault, and not getting the care that I needed. And I was only able to go and, go to an out of hours GP and get the steroids who said, you really need this. But even I was starting to question myself.
Gosh.
To have, to be able, someone going from exercising 4 or 5 times a week to not being able to walk a few minutes without being wheezy is not okay. And it really shook me up because it just like you thought, just like you said before, I'm someone who is a doctor in this healthcare system. I understand what my health condition is. I also have a rough idea of what my management plan should be. And even with those three things, I couldn't get what I needed.
Yeah.
And I felt so helpless.
Yeah.
This was last month. So
I'm so sorry.
I mean, it's fine. I'm obviously fine now. But that made me think, how are other people interacting with this healthcare system?
Yeah.
How are those people who haven't had the care that they needed, that we don't know how things have turned out?
Yeah.
What about those long-term chronic conditions things have been going and being missed?
Yes.
I wrote a complaint.
Good. Well done.
I haven't done it in previous times, but I wrote a complaint when I felt like that. And I haven't heard back. But but it's interesting because I guess what we're saying is this can happen to anyone. And actually just talking about Serena Williams made me feel a bit better, actually, that if that could happen to someone, that maybe we shouldn't be so hard on ourselves when it happens.
Yeah.
Happens to us.
I think that's a really important point. And I think what we haven't talked about yet is just there are lots of things that can be done within healthcare systems. So it's not just relying on your individual doctor to be a better listener. There's lots of kind of systemic things that can be done to make patient experience better, including, more listening and helping people navigate the healthcare service.
Absolutely. And what you said about collective organising is really helpful, because you see that with conditions or areas of health that are not that well understood. There's so many patient support groups for endometriosis, but also the power of collective organising and kind of raising awareness. So that statistic that Black women are 5 times more likely to die in childbirth, that was my supervisor at Oxford who did the numbers. That was her academic work, but we didn't know about it until you had Chloe and Tineke from 5 times more making sure that people know about it. And I always think about that in terms of the power of collective organising and bringing people together, because stats are important for us to understand the state of things and where they are. But for people to feel that and do something requires people to kind of come together and do that. And I guess what I'd like to get onto is, what can we do if you're a patient? What can you do to advocate for yourself to make this a bit better? But before I get onto that, we're talking about things that are systemic, that are broader than health, that are definitely broader than women's health and broader than health itself. And it's a problem that exists everywhere. And so I don't want to say that the solution to something that is systemic is individuals who are being affected the most. And so I guess the question is kind of, what can we do to change the system? And whilst they're waiting for the system to change, how can individuals, because it's all fine waiting for the system to change, but if you're someone right now whose doctor isn't listening to you tomorrow, what do you do?
You can't wait.
Kind of both of those questions.
I think, one thing is that we need a government that listens to its population and its patients and its healthcare staff when it comes to good health. And, that is obviously thinking about who you vote for. I think that is an important thing when it comes to improving healthcare. I think within within hospitals and, surgeries and things, thinking about bringing in, for example, protocols and policies that take away bias, for example. So a really good example comes from my specialty of sexual health and HIV, where we have opt-out HIV testing. So HIV is an incredibly treatable condition these days. People can have families, have babies, have a normal life. But there's still so much stigma around it. And we've seen that when people are diagnosed with HIV very late, so when the virus has had time to damage the immune system, when we look back at their cases, we see that they've been seeing doctors in the last few years and not had a test. And that's often because people think only some type of people get HIV. You have to be having sex with lots of people or a drug user or whatever. So what was done to kind of make sure more people got tested was to introduce opt-out testing in maternity, which was done a long time ago, like 24 years ago. So offering every pregnant woman a test. And more recently, it's been happening in emergency departments in some of the big cities in the UK. So if you're going in and having bloods, you get a test for HIV, hepatitis B and hepatitis C. So that is an example of the doctor not having to think about, does this person have HIV? Are they the type of person that gets HIV? And then just normalising the testing everyone and picking up people. So that's a way to take bias out, to take the individual kind of decision making out. So I think that's one way to do it. And I think healthcare systems aren't structurally built to listen either. So we don't get incentives for listening. We get incentives for doing tests, for giving treatments. We don't have enough time, and the environments aren't there for careful listening. So I think those are all things that can be done structurally, as well as in medical education.
It's interesting. When I said that, I felt quite hopeful. I guess one of the main examples that I use is in maternity. I see so many patients terrified of what I'm going to tell them that they have to do.
Okay.
You're going to tell me I have to have an induction. You're going to tell me I have to. Do I have to?
Right.
I don't know. I think after hearing that so many times, I just have this need to kind of just spend a bit of the time explaining you don't have to do anything. It is your body, your baby, your pregnancy. And actually my role here is to just give you access to some information that you might not have. And it makes sense that you don't have it because I'm the one that's gone through the training, and it's my job to provide you with that information so that you can make an informed decision.
Yes.
That makes sense to you. And I think even just reframing it as this is your decision, I'm just helping you with that, and we're doing that together, is what makes me feel hopeful.
Yeah.
I can't say this happens, and I don't know where that happens, but I know that happens every time that I'm with someone.
Yes.
And it kind of, and often, the people do go with what is the doctor's recommendation.
Yeah.
It's about understanding that they have autonomy in that decision.
Yes. So making that very explicit, like you've been doing.
Yeah, which is quite helpful. Also, it's just it takes the pressure off as doctor. You don't have to go in and make this. You're kind of figuring it out together.
Yes.
And also that everyone is different, and there'll be different things, different values that people have that guide their decision.
Yeah.
And how they want to go forward with things.
It feels like proper kind of shared partnership and decision making, doesn't it?
Which I do think things are changing, and I think the part of the collective organising kind of ties into that, because I say something like people only interact with clinicians for 5 to 10% of their pregnancy. All the other time they're outside, they're not with me, or they're not with their midwife. And in all that time, it's still shaping the decisions that they want to make. And so if they're interacting with patient advocates or other support groups, that's still helping them in their journey of what they want to do.
Yeah. And actually, I think patient involvement at every stage is so important. So in design of healthcare services, in research, and actually, as you say, meeting other people, so peer support. And again, sorry to go back to my specialty of HIV, but peer support has been ingrained in HIV for a very long time, and it's very nice as a clinician to meet a woman who's pregnant and newly diagnosed with HIV to say to her, would you like to meet another woman with HIV who's been in your position, who's had a baby? Would you like to talk to them? Because there's stuff that they'll tell you I can't speak to you about.
Yeah. It's amazing because I always think of HIV as an example in health. When sometimes it feels like we're doing this work and we're not moving forward.
Yeah.
But actually, this is an example of a condition that we didn't know that much about, we didn't have treatment for, and was heavily stigmatized. I'm not saying that the stigma has gone entirely at all. Yeah. But actually, it was kind of an example of where those people in power had to do something because they couldn't not, because the power of collective patient organising, and not even just patients, it was those when you had allies, right?
Yes.
People coming together, and not just the people that were affected directly, came together. And now we know that life expectancy is the same, and I was reading how sometimes people have better health outcomes because they're actually interacting with healthcare professionals.
We pick up their diabetes and their hypertension.
So it is an example of where we can look to for what works.
Yes. And that's why I use it as an example. And one of the most famous posters from the 80s is silence equals death. And I kind of use that in my head as a motif when writing the book because, when patients are silenced, they get poor healthcare, and that's what we need to change. Something I talk about at the end of my book is actually, but how can we listen ethically? And I think that's something to think about as well. So I'm very pro involving patients in everything, really. They should be at the heart of healthcare because they're the ones receiving it. But we need to listen to them ethically, so really value their lived experience and appreciate that, by continually asking people to speak about their healthcare experiences, we may be re-traumatizing them. So thinking about, how can we support them? And also payment, how do we value what they say? People should be valued appropriately for telling us and advising us, so there should be payment.
It's so interesting, that thing about going through talking about what was quite difficult can be traumatizing. I remember in 2020 being asked to go back to a hospital, wondering if you can give a talk and tell us about all the times we were racist when you were here.
Oh my goodness.
I don't know. It was hard enough living it, actually.
Absolutely.
not having to then say it again. But valuing that. How is that that issue of valuing people's experiences of healthcare and what they have to say, how is that tied into what we refer now evidence-based medicine? How does that link to what is considered to be evidence-based?
So it's very interesting. You talked about some of those conditions where there's a lot of patient power, and there tend to be conditions that we don't know that much about, like endometriosis, although I think that is changing.
Yeah.
So when we think about other conditions, for example, like chronic fatigue syndrome, and now we're seeing it with long COVID, these are conditions where patients will often say they are not heard or believed by their doctors. And these are not conditions where there's an easy diagnostic test. You can't just do a blood test and say, oh, you have this condition, like you can do with HIV, for example. So these are conditions that we don't know that much about, and we have to, as doctors, rely on patients' testimonies. So often it's a collection of symptoms. We have to believe the patient, and then we can put this all together and say, okay, yes, you have this condition, you have chronic fatigue syndrome or long COVID. So there are less objective signs. And the problem is, when it comes to medical evidence, we believe stats, we believe things that are objective, and we don't believe things, we don't believe things that are subjective, which come from patient voices. So we value things like qualitative research, which rely on patient voices and experiences, much less. It's seen as less credible. So actually that whole, what is evidence-based, what we consider to be important evidence, I think is biased towards objective evidence, and we need to be more pragmatic about what we see as being good quality evidence, and we need to involve more of that, which includes patient voice.
So I guess you explained a few things that can change things at a systemic level, right? Including who do you vote for? How does the healthcare system actually value patient voices and shared patient experiences? And whilst those are kind of the slow burning things, right? Like waiting for there to, I don't know, be policies that shape this, etc., are, in my mind, things that take time over years, if not decades. So whilst that is hopefully happening, what happens when last month someone told me my breathing problem wasn't that bad? What are the things that we can do if you're someone who you're with a healthcare professional? It doesn't have to be a doctor. You're with someone. And, sometimes you get that feeling. It's a bit of a sinking feeling. This isn't quite going. I thought it was going to be like this. And you're in that interaction. And it feels like what you thought is slowly going out of your hands. Like And if you're having that feeling, what can you do?
So I do have the whole list of stuff in the book, because as you say, the healthcare service is not perfect, and while we're waiting for it to get better, we need to be able to advocate for ourselves. So there's quite a few things I think we can do as a patient. So one thing I would say is to really prepare for your appointment. So think about what you want to get out of it, and please write a list. And I say, as a doctor, I actually love a list, because then you can make sure the patient is asked everything they want to. So prepare, bring someone with you, someone you trust, because you can then share your list with them, and they can make sure that everything that you wanted to happen has happened. And I think having someone with you is really, really important. If you have maybe you have communication needs, bring that up as well. So if you need an interpreter, for example, in the NHS, you should have access to an interpreter. So don't rely on, don't feel that you can't communicate. I think that's really important as well. And know your rights. So you are entitled to good health care. So you're entitled to complain if you're not getting it. You're entitled to ask for a second opinion. You're entitled to ask who is in charge here. Everyone has a consultant or a GP who is in charge of their care. So ask about who is in charge of your care, and ask for resources. So, what I tend to do is I will say to someone, do you want me to show you a website where you can read more about this and get a bit more information yourself? You may want to take a pen and write down the things that you say. And I often say, if you're writing down something your doctor's told you and you don't understand what you're writing down, then
that's
you need to ask them.
We haven't done our job.
Exactly. And it can be helpful to educate yourself about why you're there, or if you have a long-term condition, to learn a bit more about it, or, for example, getting pregnant or being pregnant. I don't think it's absolutely necessary, but it helps you understand. And importantly, it kind of helps the healthcare professional or doctor take you more seriously, because if they can see that you are using kind of the language about your condition that they understand, you understand it, and they may see you as being more credible. I don't think you should have to do that. But I think all those things do help. There's a really interesting study from America which showed, I think they interviewed like 1,000 African Americans, and they basically said they changed their appearance, they changed the way they spoke when they went to see their family doctor because they knew they would be seen as more credible. So they got dressed up for their appointment.
I was just thinking about mum getting dressed up.
Exactly.
To see a hair doctor as a retired GP.
It shouldn't be like that.
It's that all of these things that you shouldn't have to prepare for your doctor's appointment.
Yes.
You shouldn't have to write a list. You shouldn't have to have someone advocate for you. But everything we know is that the way that things are at the moment, those things do help.
Yeah.
Those things do work.
Yeah.
Yeah. I mean, definitely the thing with the list. I always forget, even when I'm with the healthcare professional. It's also in that moment. You've been thinking about this appointment and there's so much you want to bring. But when you get there, it makes sense that you don't remember everything. So it's just having a foresight to kind of have something to come back to.
And also I think anticipating that you might have a lot of emotions there that you weren't expecting. So you might be getting a test result and that, you might hear the result and then you're not able to concentrate for the next 5 minutes, like a completely natural reaction. So having your written list, having someone there to remind you, these are all things that can help keep it on track.
I'm just thinking of some examples of when I was thinking this is particularly to do with the labour ward.
Yes.
Because this is quite a high intensity environment.
Yes.
So I'm thinking not so much antenatal care.
Yes.
There is lots in antenatal care, but specifically about this time when people are labouring or they're about to have their babies.
Yeah.
There's a lot of power dynamics in that situation, I think. And this has been written about extensively and there are lots of words for it, or lots of related themes about people who are pregnant who feel like things are done to them and not explained.
Yeah.
Decisions are made in quite a hurried environment. And it's not to say that, this is pretty much as urgent as a lot of the healthcare system does get, but still there's an element of does it have to be that quick?
Yes,
right?
yes.
So there's the sense of urgency and not being listened to. And I was just wondering if there are things that could be helpful in that specific environment. I mean, I thought about some stuff as well because but yeah, if you had any thoughts, because this is quite different from, I think it's not, you come into hospital and you leave your hospital with the baby, right? That's what we're hoping.
That's what you hope.
That's what we hope, and we hope that you and your baby are fine.
Yeah.
But we also know that in terms of inequity in the UK, it's pretty much roughly the same. We also know that birth trauma is massively on the rise.
Yeah.
I was also thinking that, did we even have that phrase of birth trauma, and how do we even know that now? So it's quite helpful that we've got some of those words. But what can we do to, in this kind of, in that space when you come into hospital and you're leaving with your baby, what can we do better? Or what are we doing that maybe we need to do more of?
Yeah.
Are there any of those tips that you think would be quite pertinent in that kind of high intense environment?
So I think having someone with you, if possible, is, having someone who can advocate for you and be your voice, and having those discussions before you go into labour. So I don't know, because I don't work in maternity care, but I don't know if there's that opportunity in the few weeks before you're due to have those conversations with your midwife or doctor about, what would you like to happen if this happened? What if there was an emergency? What would you prefer? So there's kind of almost like a preordained kind of, this is what you said you wanted beforehand. And then obviously communicating with the person with you, whether that's your partner or whoever it is, about what you'd like to have done. I think that would be important. But I'd be interested to hear your ideas working in the area.
I mean, one of the things that you said is, it feels like there are all these new things that have just come up and I need to deal with it all now. And I think one of the things that we're certain about with childbirth and having a baby is how uncertain it is. And I often say that so often it's babies that decide when they're coming and how they're coming. It's something that changes the situation. Yeah. But even though you don't know how, for example, you might not know exactly how you're going to have your baby or when, there is so much that you can kind of understand before that time. Yeah. And it's a bit tricky in the healthcare system because I might not see someone until they're 38 weeks, until they're 36 weeks pregnant. And actually they might have wanted to know a bit more about induction of labour, I don't know, when they were 20 weeks, even if at that time it wasn't even something that could be relevant. At that time wasn't relevant. Yeah. So I think there's a lot you can do to kind of understand those situations before. And even things like, so the thing that causes lots of anxiety for patients is that my baby's dropping their heartbeat in labour. Yes. And this thing that actually, that in lots of cases is quite a normal, it's a physiological response to how the baby is responding to labour, and how, if your baby's had a normal tracing of their heart and then they drop their heartbeat quickly, that for 98% of those, they come back up. Yeah. And even just being kind of prepared on those things. Yeah. And kind of, I think this thing about a lot of birth trauma is to do with expectations and not the healthcare system hasn't prepared you for what to expect
Yes.
in all those different eventualities. So if it is that someone is recommending an instrumental delivery, you would have already understood, okay, it could be this or it could be that, and generally these are the reasons. So you've got something to hang this new information on. I think is quite helpful.
So it's not completely new.
Yeah. I don't know if that is actually, I don't know when that is going to be done. I don't know, are we going to have more antenatal clinic appointments? I don't think that's going to happen. We're not having enough clinic appointments, in terms of encounters. So whose role is it to educate you on that? Or where are the sort of resources that we go to?
Yeah.
And I also know that in pregnancy, information is actually quite overwhelming.
Yes.
Because everybody's an expert. It's not like a heart condition. You've got mums and aunts and
of course,
everyone who's got their story. And there's also this tendency, but generally it's more the negative stories that are told, because the people that have had an induction of labour and are off with their baby and having a nice time. And it's often, that in the same with, I use this example with Marina Coils, for example. You have that skew towards negative experiences, which is still helpful for you to know and understand, but also kind of take that into account. This thing about urgency, I think, is quite important, because it's actually not that common that something is an emergency in the space of minutes.
Okay.
And actually giving a bit of time. So sometimes it's maybe asking, sometimes it might feel like when the medical team come in the room and say, this is all going on, this needs to happen, you can just say, can we just have 5 minutes to think about it? You are allowed to ask for a few minutes. And if it's the case that we don't have a few minutes, then the team should be telling you that. So worst case scenario, you ask for a few minutes and they say, really sorry, in this case, it's not. That's the worst that happens. Right?
Yeah.
But don't be scared to ask for a bit more time. And also ask, that doesn't make sense. Can you explain that?
Yeah.
Sometimes we're saying, oh, we're worried about this, so we're doing that. Why?
Yes.
Just asking why. And actually, that is the job of the healthcare professional.
Yeah.
If they're recommending something, to be able to explain that to you. And so I think, I don't know, there's three things of, one, trying to understand a bit more before that time, and two, asking for more time, and three, asking why seems so basic. But actually, I think in that time, you kind of forget.
Yeah.
And also, for lots of people, they've not been in this experience before, whereas we see people in this, in this situation a lot.
Yeah.
And I think there's a mismatch between, we see this all the time, to this is your only time experiencing this, or your first time, or even, within a handful of times that you're experiencing it. So you might forget. And that is actually very common. There's a lot of other things, you might be in pain, or there's other things going on. Yeah. So I think those things are quite helpful, because it can sometimes feel like I've got no choice here. I don't know. And it's all quite overwhelming. And even the dynamics, the physical dynamics in hospital, definitely nod towards power dynamics. Right? When you're lying in bed and this whole team come around and stand over you and look over you like this.
Gosh,
and the clipboard boards are going out now because there's more things are electronic, but it's still, that itself doesn't lend itself to a more equal relationship.
Absolutely.
And then if you go to operating theatre, I think that is somewhere that can feel people can feel a bit powerless. So I often try to, if we are going for an unplanned cesarean, try and say things like, do you remember your playlist? Things like that still make that environment feel like yours.
That's lovely. Yeah.
Because often, you can't move your legs.
Yes.
if you're going to the operating theatre for an obstetric reason, you're lying down on your back. You feel rubbish, and that might continue. And bright lights in this very sterile environment, all these people looking down on you. And even though the team, should be all working together for you, it can feel like basics, just basics of not being able to feel things. Yeah,
so you're most vulnerable. Yeah.
So thinking in that time, whilst this decision has been made where you're going to theatre, between now and then, what can you do to try and make it feel like you're still your experience? Because it is still your birth. Yeah. That makes sense. Not kind of, just things I've been thinking about. I don't have the solutions, but it'll be interesting. I mean, most of this should probably come from patients, because they're the ones experiencing it, rather than us coming up with the ideas, right?
I think it's a start, isn't it? That's really interesting to hear your suggestions there. I wondered, so one thing I talk a bit about in the book is about continuity of care, and how, if you get to see the same healthcare profession over a period of time, it makes things much quicker, safer, and, just more efficient. I don't know if that happens in maternity care anymore. Do you get to see the same midwife?
It's a good question, continuity of care. So sometimes people have one midwife, and they're called like case loading midwives. So you will see the same community midwives a lot of time. But if you're seeing your midwife predominantly in the hospital, it can be different people. Yeah. And we know that with doctors, it's very unlikely to get continuity of care. It's interesting what you say about how it makes things easier. And I imagine it also increases trust.
Yes.
that you don't have to spend the first 5 to 10 minutes building that relationship, figuring out just for me, that those first few minutes, you're figuring out what's important to this patient, what can I do to help?
Yeah.
And actually, if you know a lot of that already, then you can get to it.
Yeah.
But currently in the UK, the healthcare system does not, the NHS doesn't, that's not how it works, which is a shame. But I often do find it's when I see patients again, even though it's not built for that, I'll see someone who's come through maternity triage, and then I see them again, I was like, oh, you know that, and I was like, how does that work? And they're like, oh yeah, that prescription worked, thank you, or like, oh, that kind of stuff. And
makes our jobs more enjoyable, doesn't it?
Yeah, it's also more fun.
Yeah,
you know, it's also interesting because I've thought about, I haven't, not so much continuity of care, but I've thought about how being a clinician who's going through, you know, training programs, and we're being trained to be better clinicians, continuity of mentors and the environment. Yeah, that actually, if you're with a different team every day, you're spending most of the time trying to, you know, so people know who you are and where you're at. Whereas if you're with the same team, you know, for a prolonged period of time, they know who you are, they know what your strengths are, what your weaknesses are, and you've got that shared experience. And I think it's the same for patients.
Absolutely.
Yeah, and I know that people talk about this they talk about firm structures, how we used to have firm structures in terms of how doctors were trained, that you would have, this is the team that you would work with. And we know that is less common now, and then there's been a bit of a push or pull to kind of bring that back. But yeah, I think it's the same thing with patients. Do you know if there's any drive to kind of change that, or
in terms of continuity?
Yeah,
I don't know, to be honest. I've talked about it mainly with regards to general practice. So, you know, family doctors used to see a person over a lifetime, and just unfortunately the way general practice is changing, it's going against that, although people are trying to fight for it to come back. What you were saying about being the same kind of people that you work with for doctors as well is important. So, you know, I've talked about how we're not very good at listening when we're uncomfortable with hearing things. But actually, when that happens, if you acknowledge to yourself, I'm not sure that was a great consultation, it's really helpful to debrief to someone in your team. Like, I'm not sure what I could have done better then. And I think, you know, having more supervision, having more mentoring, having opportunities to really debrief what are difficult scenarios would be really helpful in all aspects of the NHS, because it would help us all learn as medics how to be better, but it also takes some of the stress off us. And it would help things like compassion fatigue and burnout. You know, you're not going to be able to listen if you're burnt out.
No, and also thinking the parallel of, we offer patients who not been happy with their birth experience to come back for a debrief with a consultant. But it'll be quite interesting if we could also have more common debriefs about, I know what you mean. Sometimes you have a consultation, you're like, I think that could have gone better, but you're not sure exactly what it is, just to talk through with someone. Yeah, I didn't really think about that, actually. I wanted to ask a little bit about, I think you mentioned something about, we often ask patients to speak up, but that's not that easy, about why that is.
So it may not be safe for some patients to speak up. So going back to the example of when I was in hospital, when I tried to speak up, I could just see people rolling their eyes at me, and you know, I could just see they thought I was annoying, I was a nuisance. So it didn't feel very safe for me to speak up. I didn't want to be seen to be more of a problem patient than I already was, because I've been on the other side. I've been in healthcare teams where, you know, there's someone on the ward and you're like, oh, that patient's hard work, because they keep asking for stuff. So, you know, you can, unfortunately that does happen. It shouldn't happen. So you may not feel like you want to be seen as a problem, which may put people off speaking. If there's a stereotype, so example, you talked about Black women being seen as being, you know, angry or aggressive, or Asian women being seen as being anxious. If you speak up, you may go more into that stereotype, and people may then stereotype you further. You might be less likely to be believed. And also in healthcare, we're at our most vulnerable. We're not at our best. We're not at our public speaking personas.
Yeah, we're not ourselves. Absolutely.
You know, we might not be able to speak up at all. And, you know, because you've had previous bad experiences, you may not trust the healthcare institution that you're in to be able to respond appropriately. So I think there's lots and lots of reasons why people don't speak up, and we shouldn't expect them to. We should be changing things.
That makes sense. I was wondering if we could finish with a summary of why is it that some people are listened to, others are not listened to? Why is it that we know some things, we know lots about certain conditions, not much? And then just finishing on what you can do if you're a patient.
So I'd say, sadly, due to societal bias and prejudice, some people are just seen to be less credible when they speak up. They're less likely to be believed. So, for example, a woman of colour may be less likely to be believed in healthcare and taken seriously than a white man. So these are some of the reasons why people aren't listened to and aren't heard. And this can affect conditions that they have. So thinking about common, gynecological conditions like endometriosis, we have a huge research gap. We don't really know what it is. We don't know how to treat it. And we don't know how it affects pregnancy and fertility and what happens in menopause. So big gaps. And that, I think, is because women have not been heard for centuries when it comes to gynecological issues. So that means that people have not been interested enough to do the research and to find out what's going on.
I guess the final thing is, if you are with your healthcare professional, and I mean, this is not just if you are pregnant and with your healthcare professional, but you're with them and you feel like you're not being listened to, or you feel something's not right. What are the things that you can do? Or maybe these are even before you get to your healthcare professionals, just practical things that you can do to improve the health care that you receive, care that you receive.
So firstly, I'd say prepare. If it's an appointment or whatever it is, prepare for it, think beforehand, what do you want to get out of it, write things down beforehand. So have your list, take someone with you. So if you're not able to say everything that you want to say for whatever reason, someone can do that for you. Know your rights, so know that you can complain, know that you can ask for a second opinion and this shouldn't affect your care. Ask to know who's in charge of your care, so you can speak to that person if you need to. And ask if you want to speak to the same doctor, is it possible to speak to someone that knows you? And ask for resources, so something that you can take away with you or read when you're not there. So, for example, is there a website they'd recommend so you could find out more about their condition? And if it's possible, are there any other patients with the condition that you can speak to? Is there links to charities where you might find peer support, or you can, create community with other patients?
It's clear that you've thought about this.
2 years.
Exactly. And I guess the things I would add are, if you're specifically in this environment of when you're about to have your baby, kind of things that you can do, I guess something that you can do before that is take in as much information and do lots of your weighing up before that. And also expect that things will change. Lots of people, for example, have really fixed opinions of whether they want an epidural or not, for example. And if it's their first time having a baby, I often say it's good for you to understand the risks, the benefits, when it would be useful. But if you've never experienced that pain before, how would you know if that's something that you need? But so understand as much as you can outside of that environment, but also be flexible that you might change yourself. And then this thing about time, that ask if there's something that's been recommended or something that's supposed to happen as a change of plan. Ask, is it possible to have a few minutes to think about it? And if it is that it's an emergency, then your clinician should tell you. And this last thing of kind of trusting yourself. If it's something doesn't feel right, say ask. And often people will know themselves and their pregnancies better than anybody else, right?
I think that's such an important last point to make, is trust yourself. People often talk about feeling gaslit, don't they? So you start to doubt yourself. But that's so important to have that gut feeling, trust your gut feeling.
Because you're the one that's been living with pregnancy. Well, just not even just pregnancy, you're the one that's living with yourself, and you will know that better than anyone.
It's your body.
Thank you so much.
Oh, you're welcome. Thank you so much for asking me.